Hello and welcome to the Newborn Toolkit webinar. Today we're looking at the neonatal workforce equation, how many and how fast. So welcome, and please feel free to introduce yourself in the chat with your name or where you're joining us from today and your background or your role. Next slide, please. So the Newborn Toolkit seminar series aims to enable multi-country, multilingual learning for high-quality small and sick newborn care. And this is in alignment with the National Targets Sustainable Development Goal 3.2 for newborn survival, which aims to reduce the number of national newborn deaths to less than 12 per 1,000 live births. And the webinar series concentrates on high burden settings, including sub-Saharan Africa and South Asia. In 2025, we had over 62,500 unique users from over 170 countries. On the Newborn Toolkit website, there's over 1,250 tools in over 15 languages, and technical content on the site is also available in French. Next slide, please. So the Newborn Toolkit seminar series aims to go faster together. We focus on the 10 core components of health system strengthening created by UNICEF and WHO. And you can see those core components on the cog on the left. If you're interested in keeping up to date with Newborn Toolkit activities, including events, publications, and other ongoing things, you can sign up to our newsletter. We have one in English on the left on the QR code, and French as well. And you can also follow us on our social media channels, including Blue Sky, Twitter or X, LinkedIn, and Facebook. Next slide, please. So we also have a few upcoming webinars. So on the 4th of August, we have a webinar looking at most fragile babies in fragile contexts. How do we support breast milk feeding? And on the 8th of September, we have a World Sepsis Day webinar, which you are welcome to join as well. And you can access these on our events page, which is also shared in the chat. Next slide. Donc, bonjour et bienvenue à tous nos participants parlant français. On a aussi quelques webinaires à venir. Le 4 août, on a un webinaire sur les bébés les plus fragiles dans les contextes fragiles, comment favoriser l'allaitement maternel. Et le 8 septembre, un webinaire à l'occasion de la Journée mondiale contre la septicémie. Donc, nous vous invitons à nous rejoindre pour ces événements. Next slide. And without further ado, I'm very excited to introduce our two fantastic co-hosts for today. So both neonatal nurses. Patrick, too, is the chairman of the Association of African Neonatal Nurses and the non-executive director of the Council of International Neonatal Nurses. And we also have Edith, who has hosted some of our webinars in the past, and we're excited to have her back again. She's the Director of Clinical Training for NEST 360 and Treasurer of the Association of African Neonatal Nurses. So without further ado, I will pass over to Patrick and Edith to take it from here.
Thank you so much, Lauren. Good morning, good afternoon, and good evening to everyone joining us from around the world. Welcome to today's session, the neonatal workforce equation, how many, how far, fast. It is part of the implementation toolkit for small and sick newborn care webinar series that we've been having. I'm delighted to co-host today's sessions alongside with Edith Kishia. So whether you are joining as a clinician, an educator, a policymaker, a researcher, an engineer, or a partner in newborn health, we are grateful to have you here with us. So today's sessions asks important question, not only how many healthcare workers do we need, but how quickly can we educate, deploy, and support them to meet the growing demand for newborn care. We encourage you to submit your questions throughout the webinar using the Q&A function. So without much further ado, it's now my pleasure to introduce our first speaker, who is Jean-Pierre Monet, Technical Officer, Department of Maternal, Newborn and Child Health, Adolescent Health and Aging, World Health Organization. So Jean-Pierre will provide an overview of the WHO standards of neonatal care and human resources needed to implement them. Welcome, the floor is yours.
Thank you so much, and good morning, good afternoon, and good evening, dear colleagues. I'm delighted to make this first presentation on behalf of my colleague, Dr. Quinn Dubé, on WHO standards and norms for optimizing health workforce for neonatal care. Next slide, please. As background, we wanted to remind all of us the urgency to accelerate progress over the next 4 years to reach the 2030 targets. So you see here on the slide the average annual rate of reduction for maternal to reach the maternal mortality target. So it's about 15% over the next 6 years. The one for reaching the neonatal mortality target is about 10%, and for reaching the target on reduction of stillbirth rate is about 7%. And what is really concerning, as you see on the graph, is that these accelerations are much higher than what we have observed in the past, especially since the beginning of the SDGs period. Next slide, please. So having enough competent and health workforce is of course critical to support these accelerations. And we wanted to share the preliminary results for Human Resource for Health of a survey that was conducted by the Every Woman, Every Newborn, Everywhere, or IWINI partnership in 103 countries. Next slide, please. So you can see that compared to the baseline of 2022, we have more countries having national strategy or plan for human resource for MNCH compared to 2022. Next, please. And in most countries, core competencies are defined for human resources. And you see here that 72% of countries responded having competencies defined for nurses for small and sick newborn care. Next, please. But then you see that fewer countries have norms defined on the required number of midwives, especially in level 1 basic EMONG facilities, and also in number of nurses for small and sick newborn care units. Next slide, please. So compared to 2022, more countries also have introduced provision for equitable distribution and motivation of human resource. Next. And on this slide, you see examples of financial and non-financial incentives that are highlighted by countries. Next. So, of course, the upcoming EWIN report that we will be released in September will provide more information on human resource and on these results, and also on the other component of health system for supporting newborn care. But next slide. Some of the key messages and principles that WHO and partners will clearly highlight in this report are that better outcomes and required acceleration needs a stronger workforce system, not just more staff. We all know that increasing the number alone does not consistently improve maternal newborn health outcomes. So result and acceleration depend on 5 system capabilities that are highlighted here. So planning the health workforce in terms of using global norms and local workload, making sure that we have teams deployed in health facilities with clear scope, optimized role, and making sure that there is a strong collaboration between midwife, nurses, doctors, community workers, and linkages with referral systems. Of course, the competency, aligning pre-service education, simulation, mentorship, and continuing development to evidence-based maternal newborn health standards, and driving towards the provision of quality and respectful care 24 hours, 7 days a week. And last but not least, of course, the importance of retention and motivation with fair pay, safe workloads, supplies, housing, or rural incentives can career path. And several of these components will be further discussed in this webinar, but we wanted to specifically highlight 2 of them, so the one on planning and the one on competencies. So for the one on planning, and especially on the global norms, on the next slide, please. WHO has co-led, next slide, please, with UNICEF, the development of global norms for small and sick newborn care. And this will be released by the end of this year. And as you see on the slide, there are 4 components as part of the development of these norms. One on the number of small and sick newborn care units and the number of beds required in these new units, one on the travel time to seek care, one on the space requirements for the units for both the newborns and their mothers. And then finally, I mean, the one that we are specifically interested for this webinar is the optimal health workforce ratio for small and sick newborn care. And so the norms that have been defined and that will be released on the next slide are the ones follow. So I will, for sake of time, I will skip the ones on the number of units, but you see here the ones that are defined per 10,000 live birth. Then if you go next, you have the square meters that are defined per CPAP, non-CPAP beds in the for the units. And then finally, you see the one related to the ratio, nurse newborn ratio. So basically, the one defined is that there is a need of one nurse to 3 to 4 newborns per shift, as recommended for small and sick newborns not requiring CPAP, and one nurse to 2 newborns per shift recommended for small and sick newborns requiring CPAP. So nurse or equivalent health worker with needed competencies to provide level 2 newborn care. So these are the norms that are defined. Of course, countries and program managers should make adequate provision for annual leave, days off, and making sure that the shifts cover 24 hours period. And there is opportunity using the WISN tool, and we have put the link here. So the workload indicator of staffing need, which is a WHO tool, for countries to refine these global norms to their specific context. Moving on to competencies on the next slide, we wanted to highlight that WHO released in November 2025 an essential newborn care course that is available here on the link, and that basically can be used in both in-service and training and orientation and pre-service education. And on the next slide, basically, this course is based on the circle of learning and improvement, including practicing simulation in teams in health facilities. So the next slides provides you some of the new elements in this second edition. So of course, it's aligned with the recent WHO recommendations. It applies contemporary educational methods and has specific focus on quality improvement. So on the next slide, you see here some of the, next slide, please. You see here some of the modules that are accessible, and you see that there are 3 cross-cutting modules, including one on data collection and use, one on communication and respectful care, and one on infection preventions, and then you have 10 thematic modules that are available. So in addition of this essential newborn care course, on the next slide, there are 2 ongoing products at WHO. One course for small and sick newborn care under development, and also a WHO maternal newborn healthcare competency framework for midwives and OBGYNs that is also under development. So the one on the next slide, the course for small and sick newborn care, will of course focus on frontline health workers for level 2 newborn care units and may be adapted for pre-service education, and it's under testing currently in Nepal and should be published beginning of 2027. And next slide. So all these materials and also the norms are also aiming to support successful transition to facility-based learning for both pre and in-service learners. So I thank you, and I stop here, and I'm available for any questions you may have. Thanks.
Thank you so much, Jean, for setting the base on framework for understanding what WHO standards require from our workforce perspective. Our next presentation moves from standards to practice, practical workforce planning, by asking a question that many countries are currently grappling with. How many neonatal nurses do we actually need, and what investment will be required? So it is my pleasure to invite Alice Talus, who is a research assistant and health economist at London School of Hygiene and Tropical Medicine. Welcome, Alice.
Thank you so much, Patrick, and pleasure to be sharing some of the learnings that we have. And we'll be talking about how can we use the economic evidence to inform closing nursing gaps for newborn care. Next slide. Next slide, please. So in terms of closing the nursing gaps, and especially thinking about small and sick newborn care at level 2 units, there are two main gaps that we are closing. So the nursing gaps in terms of the numbers. We know that the nurses are primary providers, yet most of the hospitals have suboptimal ratios. And when you think about, we did some work with Tanzania government to estimate the national scale up. And what we estimated as a gap was more than 2,500 nurses needed to be able to meet the 80% coverage across all the units. And in terms of the skills, we recognize that the skills that they do have some of the skills, but is not enough to be able to provide quality care. And considering the few that we already have that are frequently rotated. And the second gap is on money gap. Newborn is one of those interventions that sort of came a bit late into the global health space. So funding is minimal, and it's even worse considering the changing funding landscape. And also just recognizing that salaries, where nurses are also a major part of the team, they contribute as main expenditure, more than 50% of the recurrent cost. So recognizing this, we can be able now to use the economic evidence to inform efficient HR planning and make the case for more numbers and more resources for newborn health. Next slide, please. So how can we use evidence to close these nursing gaps? We all know that in our setting, the low middle income countries, we have limited resources. We need to allocate to every intervention. And how can we help countries to invest in newborn survival to meet SDG 3.2? Can they focus more on general nurses, or can they focus more on specialized nurses? So when you think about numbers, increasing higher nurse numbers with general nurses, or go specialized, focusing more on specialization, ensuring that the nurses who are providing care in the newborn unit are trained, maybe through a post-qualification training, which varies across countries. It can be 1 year, 2 years, depending on the curriculum. Click on the next animation. So if you think about the duration to meet the SDG target, we need the skills and we need the numbers. So if you think about going all out and ensuring they are specialized, or increasing the number of general nurses and having a midway in between, so increase the staffing numbers and offer targeted on-site training on some of the neonatal competency on site, so that we are not removing nurses from the newborn unit, but we are ensuring that they continue to provide care and even as they get the skills. Next slide. So this work that we are presenting in the subsequent slide, it has been done as part of NEST. And NEST basically organization of 23 organizations, 18 of which are in Africa, focusing on three main pillars: the technology, the education, and the data. And mainly looking at the data that we do have in terms of the nurses, having the day and night ratios to be able to inform planning as well as decision making, and looking at the scope currently within 5 countries: Kenya, Nigeria, Malawi, Tanzania, and Ethiopia, and across 130 hospitals. Next slide. Next slide, please. So what analysis did we do? We estimated nurse to baby ratios and accounting for the clinical acuity using CPAP as a marker of complex need, and we costed the scenarios. In terms of how we did it, first, we used the primary data across the NEST implementing countries, that is Kenya, Malawi, Nigeria, and across 66 hospitals. Then after that, we estimated the nurse numbers and skills to close the gap, and using a standardized neonatal unit. And this linking back to the first presenter who was talking about the recommended ratios, but then we standardized this using the Tanzania flow plan for level 2, that is a 40-bed unit that has 10-bed high dependency unit that requires CPAP, and 30 beds for low dependency, including KMC and the rest. And the third objective, we looked at the cost of scaling up nurses in Malawi, that is applying the ratios to estimate the nurses needed for day and night ratios and accounting for CPAP as well, and estimating the gap, the cost in terms of salaries to be able to close the gap needed. Next slide. In terms of the data that we used, so we used 3 levels of data: patient level data, health system data, as well as the cost data. For the patient level data, we used the neonatal inpatient dataset, which has data for every newborn who is admitted. And for the year of analysis, it had over 100,000 babies. And for the context tracker, mainly providing in the number of nurse ratios for each hospital. And for the cost data, we are using the government salary scales for nurses, especially for Malawi, and using the 360 training tracker to understand the trainings that has been done across these hospitals. Next slide. So from the results, looking at the current implementation across the 66 hospitals and across the 4 countries, and recognizing that among the dataset, Malawi had 37 hospitals at a national scale, a mix of district and referral hospitals. And what we see here as the median nurse to baby ratio, if we start with Kenya across the 13 neonatal units, the ratios are really 1 to 20 for the day shift and 1 to 24 for the night shift. And out of the 21,000 babies who were admitted, 13 of them needed CPAP. And if you go to Malawi at a national scale and having some the different hospital types, the day ratio is 1 to 6 and the night is 1 to 11, so around 57. And for the 57,000 babies admitted, 20% needed CPAP. If you go to Tanzania, across the 7 units, the ratio is even higher at night. And for the babies who needed CPAP, is around 17%. Next slide. So estimating the number of nurses and standardizing this, linking to the UN ratios that has been presented. And here we are accounting for a 12-hour shift and no prior staffing. And from the data that we have just presented, if you take the mean ratios, it means you have 1 nurse for 9 babies for all admissions. And if you go all out according to the UN norms, we need 1 nurse for 2 babies who need CPAP and 1 nurse for 4 babies for non-CPAP. And in between, based on where most of these countries are, if we estimate for 1 nurse for 4 babies as a halfway scenario for all admission, and you have 1 neonatal nurse as the lead for every unit. So possible scenario that countries can start thinking about even as they move from their current numbers to meet the recommended staffing ratios. Next slide. So standardizing this based on the Tanzania floor plan, 40-bed unit, and here we're working with nurses based on 100% daily occupancy of the unit and on a 12-hour shift. What we found out is that the current mean across the hospital, we estimated 5 general nurses, recognizing that the data really didn't spell out the difference between specialized and general nurses. And if you model this into the 2 scenarios, best case scenario where you're going all out and accounting for the clinical acuity, and recognizing that the general nurses will provide care to the non-CPAP babies, and the neonatal nurses will provide care to babies on CPAP. We'll need 8 nurses, general nurses per shift, and we'll need 5 neonatal nurses if you go for a ratio of 1 to 2, and halfway in between you'll need 10 general nurses, and this gives us 30 nurses for the 24-hour or per day, and this also account for the time of the annual leaves, the maternity leave as well, and halfway we'll need around 24 nurses for a 40-bed unit. And when you look at what we do have across the hospitals within NEST, it's 12. So meaning even the hospitals need to double their ratios to get into the staffing norms as recommended. Next slide. So costing for Malawi and analyzing the gap that they need to close, what we found out that for them to move from the current estimate to reaching the norms, they will need to increase nurses by 343 per day. And this is reflecting more, a lot of nurses will go to night shift. For instance, here we're talking about over 200 nurses for the night shift and 142 for the day shift. And if you come halfway in between, they will need 250 more nurses to reach the halfway scenario. And in terms of the cost and reflecting more at a hospital level, so hiring general nurses only, it will cost an additional 85,000 USD per hospital. And if they mix the general nurses based on the clinical acuity and having the skill set, then they will need 129,000 per hospital based on the ratios that we have just presented, and 211,000 for the best case scenario. Next slide. So we went ahead and tried to map possible ways that we can be able to move the training within this space, and we map them into 3 tracks. So the first track is in-service training, where you have general nurses or the midwives who have some experience within neonatal care, going through a very short course that can take a few days or a few months to be able to just get some skills on newborn care, and it can be done on site or a mix of both on-site and hybrid. And the second track is whereby you're now taking these general nurses with some of the working experience, but then they're going through training to be able to gain more expertise in neonatal nursing. And this is mainly linked to a period of 1 to 2 years, depending on the countries. And also thinking about the training mode is more of a face-to-face with some of the clinical rotations in tertiary hospitals. And track 3 is on master's level, so where they sort of go to a specialized neonatal nursing school and aiming to be more of the educators, more of the mentors, and getting into more of a research. So they're away from practice for the duration of the study. And this more linked to a university curriculum and clinical rotation in the attached hospitals. If we click on the next animation on the tuition fee. So for the tuition fee for the track 1, which is on-site, it's sort of variable depending on the training mode that it's adopted. For the training track 2, it ranges between 1,000 to 2,000, depending on the mode as well. And the training track 3 is around 5,000. So clearly this tells us that moving ahead as we sort of master the neonatal nursing, it becomes costly, but also it takes the few nurses available from the neonatal unit. Next slide. So for Malawi specifically, we mapped out what is available in terms of the training based on the 3 tracks. So for the training mode for track 1, so there's a 5-day offsite training supported with a low dose high frequency plus mentoring in a hub and spoke model. And this is being implemented by the government at a national scale. In terms of the government recognition, so there's no pay increase per se, but then they're recognizing other roles, such as being a mentor for the neonatal units. And for the track 2, what we found out is that there's a training mode at COHES, 1-year child health nursing diploma, or the 2 years of the 4-year BSc neonatal care, mostly which is self-sponsored, which can be also costly. And then for the track 3, we found out 2 options, the MSc nursing and child health nursing at COHES as well. And with this, it's more self-sponsored, around 11,000 USD. And this allows them to be recognized as a new job group, meaning higher pay and more motivation. And what this really means is that even as we think about scaling neonatal skills, it's more balancing what can be done now to meet the the SDG targets, but also what can be done even as we try to build the skills, to transfer the skills across the country. So balancing both, what can be done even as we build the skill expertise over time. Next slide. In terms of the actions and based on what we have seen, so across the hospitals, across the 4 countries that are implementing with NEST 360, the current ratios are still way below. So there's need for more advocacy to be able to get to the recommended ratios, and also just being able to use this evidence in terms of HR planning, investment, allocation, and all that. And also recognizing that a neonatal nurse as a cadre and advocating for more pay for that. And even as we increase the number of nurses, there's also need for us to think about system planning at the hospital level, because as the data has shown, the ratios are very, they are sort of very suboptimal, especially at night. So ensuring that the planning accounts for those systemic issues related to few nurses at night, and even the rotation where nurses are being taken away from the newborn unit. Thanks.
Thank you so much, Alice, for that insightful presentation. You've highlighted not only on the scale of nursing shortage, but also on the importance of investing wisely on the workforce. We'll now hear an example of how one country is responding to this challenge. Please join me in welcoming Dr. Jody Sarin, who will share India's approach to building neonatal nursing capacity across the country. Next slide. So
Greetings
Dr.
from
Jody
India.
Sarin, sorry.
Yeah.
Dr.
Thank
Jody
you for
Sarin.
introducing. Yeah. Greetings from India and Indian Association of Neonatal Nurses. I extend my heartfelt gratitude to the organizers of this webinar for having me here to share with you India's approach to building up resources for neonatal nurses across the country. Next slide, please. India accounts for more than 40% of global burden of low birth weight. 30% of the country's total annual live births are born with birth weight less than 2,500 grams. And of these, 60% are intrauterine growth retarded and 40% of them are born preterms. The prevalence of birth defects in the country is 6 to 7%. Next slide, please. Major causes of the neonatal deaths, as you can see on the slide, are prematurity, birth asphyxia, and neonatal sepsis. May I have the next slide? The survival trajectory of these fragile infants is directly proportional to the nurse patient ratio and the specific competencies of the nursing staff attending to them. This slide shows that India is moving in the right path and achieving the rates as desired by the SDG to be till 2030. Next slide, please. There are many states in India which have already achieved the target which they are expected to achieve by 2030, but there is a wide disparity amongst the region. There are states in India which needs to put more efforts to achieve the target of 2030. And here what we can see is the lack of adequate manpower is one of the major constraints which is resulting in as a barrier for achieving the targets of 2030. The next slide, please. What we see here is that there is a stark gap between the identified need of the nurse patient ratio and in reality what exists in the SNCUs, that is special newborn care units, and it definitely has impact on quality care of the neonates. Next slide, please. As we can see here that Most of the SNCUs are manned by general registered nurses. They are either general nursing midwife or with BSc nursing graduates. And they have undergone facility based newborn care training, which ranges from 4 to 14 days. But for level 2 and level 3 care, which needs complex competences, there is a need of having specialized neonatal nurses. May I have the next slide? Ground level heroes are ASHAs, that is, accredited social health activists, and ANMs. While facility based care battles staffing shortage, India's grassroots network of ASHAs and ANMs is fundamentally transforming neonatal health at the community level. This community level nursing workforce bridges the gap between institutional delivery and long term infant survival, bringing essential care directly to rural doorstep. In the next slide, we will see the impact of community care on neonatal health. As we can see this slide, that ASHA workers have significantly contributed to detection of danger signs at the early time, reducing mortality and ensuring nutrition and kangaroo mother care, as well as thermal and cot care, which definitely have impact on thermal protection, cot care protection. It is resulting in exclusive breastfeeding, and we have timely referral, so the mortality has significantly reduced. The next slide is depicting the first Golden Minute initiative, which is an collaborative attempt by Indian Academy of Pediatrics and other organizations recognizing the critical severity of neonatal mortality. And this program was launched in 2009. It is related to neonatal resuscitation program, successfully trained over 70,000 healthcare personnel in basic as well as advanced neonatal resuscitation program, and there is a need to scale it to train 200,000 health professionals with a singular driving goal, ensuring that at least there is one neonatal resuscitation program trained expert present at every single delivery across India. May I have the next slide, please? These are the insights from the India Newborn Action Plan, that is INAP, where we can see lack of appropriate manpower and trained skilled workers was identified as a key bottleneck to service provision and quality of care. It means there is a dire need to train manpower and have the skilled providers at the neonatal care units. Next slide, please. For workforce development, National Rural Health Mission has significantly increased its technical human resources. The current supported workforce includes 38,421 staff nurses and 2.39 lakh auxiliary nurse midwife. The workforce is further supported by paramedics across the country. At the community outreach level, over 8.95 lakh ASHAs, that is accredited social health activists, have been selected, with more than 6 lakhs trained in home based newborn care. Next slide shows us that what are the strategic human resource policy and planning to address workforce bottlenecks. INAP emphasizes the formulation of a comprehensive national human resource health policy in concurrence with the National Health Mission. A major action point is establishing a roadmap specifically for strengthening nursing pre-service education. Next slide shows us that to combat major causes of newborn deaths, the government has authorized critical task shifting for ANMs. Now, ANMs are authorized to administer pre-referral doses of injectable antibiotics for suspected neonatal sepsis, and they are also permitted to administer pre-referral doses of antenatal corticosteroids to women in preterm labor. These policy decisions empower nurses to provide immediate, life-saving interventions when referrals are delayed or not possible. The next slide depicts empowering nurses through policy shifts, task shifting. INAP prioritizes expanding the availability of skilled birth attendant trained personnel at every delivery point, and I am very happy to announce that this target has been achieved by India. We have more than 80% coverage that all the delivery points are having SBA trained ANMs and staff nurses. Over 1.3 lakh health providers have been trained under Navjat Shishu Suraksha Karyakram. This training delivers basic newborn care and neonatal resuscitation skills to staff nurses, ANMs, and lady health visitors. The next slide will depict that capacity building and training program, which is the focus area of INAP. Quality assurance and supportive supervision relies heavily on the capacity of facility and community level human resources. This calls for scaling up and strengthening skill labs for pre-service and in-service nursing training institutes. It emphasizes revitalizing the role of ANM to act as a supervisor and mentor to ASHA workers in the community. And to maintain high standards, the plan recommends regular performance-based incentives and formal accreditation for trained frontline workers at regular intervals. The next slide depicts various insights from facility-based newborn care. Next slide, please. The
Jody, we
Ministry of
may
Health
have to wrap up a bit
Yes,
quicker if that's okay.
in 2 minutes, yeah.
Thank you.
These are the initiatives which have been taken up by Ministry of Health and Family Welfare to develop the workforce. We have midwifery-led training institutes, which are 7 in number right now, and there is a Dakshta training program. It is 3 days training capsule. May I request you to just run through the slides? I will also like to share with you that these are the various programs which have been launched by Government of India for strengthening the in-service training workforce. Similarly, various efforts have been also placed for strengthening the pre-service nursing curriculum. We have a revised curriculum where we have competency-based nursing curriculum, facility-based newborn care module, and essential newborn care module have been integrated into the nursing curriculum of the undergraduate program. We have master's program where we have emphasis on the neonatal nursing clinical experience, and similarly we have post basic diploma program in neonatal care, and we do have neonatal nurse practitioner program which has come up in the stream right now. Indian Association of Neonatal Nurses, in collaboration with National Neonatology Forum, is taking various efforts to conduct regular annual workshops, pre-conferences, as well as to collaborate with NNF to empower our neonatal nurses. So to conclude, while India has made remarkable progress in reducing infant mortality, Ensuring the quality of facility-based care through adequate skilled human resources remain the critical next frontline things to be achieved. Thank you so much for having me here, and I will be very pleased to have any questions regarding it. Thank you.
Thank you so much, Jody. And it's quite inspiring to hear how national leadership, education, and strategic planning can transform neonatal nursing capacity. So at this moment, allow me to invite our next presenter. Now we shift our focus to Africa and explore the role of specialized fellowship training in development of future leaders for newborn care. Welcome, Dr. Minette Coetzee, who is the Director, Children Nursing Development Unit, University of Cape Town. Welcome.
Patrick, I'm very grateful. Oops.
Yes,
Minette, you're muted.
You're muted. You can unmute.
Forgive me. Oh, that's better. I'm sorry, I had a big echo. Hi, my name is Minette Coetzee. I'm based at the University of Cape Town. I lead a nursing training and scholarship unit, which essentially is our goal is to build children's nursing across the continent. Next slide, please. In the Department of Pediatrics and Child Health at the University in Cape Town, we've been training both doctors and nurses who work with newborns for the last 20 years. Parallel, but different streams. Next slide, please. The medical program is called the APFP program, African Pediatric Fellowships Program, training neonatologists, subspecialists from across the region since 2012. The fellows are medical doctors with a qualification in pediatrics who come to UCT for a 2 to 3 year MPhil in neonatology, making them subspecialists, so pediatricians and then subspecialists. That leads to a qualification registration with the health providers. Of course, each of these neonatologists heads home to these different countries and knowing and asking that they need neonatal nurses to build and sustain neonatal services. Next slide, please. I'm turning my focus to nursing, and the nursing regulatory pathway is much less simple in most of our countries. Let me use South Africa as the first one, as an example. The South African regulator, also called South African Nursing Council, does not yet have a neonatal nursing register. For a number of years, until 2019, the advanced midwifery and neonatal nursing was a joint qualification, mostly training midwife with a strong midwife focus. And without that neonatal nursing register, no professional standards against which to train to accredit training programs. But I'm not here to tell you a bad news story, rather an unapologetically African narrative of finding what works and planting what grows. So let me start here in my own space at the tip of our continent. You can, the next slide, please. So finding ways around not being able to register neonatal nurses. And you'll recognize these pathways from some of what Alice described. I'm doing them historically. We established a postgraduate diploma in pediatric intensive care nursing. And in that included intentionally NICU modules. Over that period of time, trained 124 graduates. In 2015, we started training a master's in nursing, in children's nursing. So we were training advanced nurse practitioners. This program allows not graduate students who arrive to choose the direction of their focus. And 9 of the 30 graduates were then trained in neonatal nursing. That means being placed in NICU settings from primary through to NICU settings. In 2020, we welcomed one of those graduates onto our teaching team. And Edith and Patrick, you'll recognize her. She's a colleague of yours as well, Noslatlam Tolo. And she led the development of a CPD course called Essentials of Nursing Sick Newborns. It's a UCT accredited course. It's a CPD course. It gets offered asynchronous and online over 16 weeks. It runs twice a year. And 138 nurses have graduated from 16 countries in the last 2 years. Now, that really that sounds like 271 neonatal nurses. Next slide, please. So creative ways might upskill nurses, but that doesn't add measurably to the workforce. Without a national regulator register, anyone gathering data in South Africa would have to conclude that we probably don't have trained or qualified neonatal nurses. Next slide, please. Currently, this is not the case on the rest of our continent or in our region. A rapid and by no means thorough review from neonatal nurse leaders revealed that at least 12 country regulators do accreditate neonatal nursing nurse specialists. And I see Malawi is not on here. And after Alice's presentation, I'm pretty sure that that is a register that's active in Malawi. Having said that, there are now more than 15 neonatal training programs being offered across these countries. And we've been offering them in this region, probably, when I say we, I mean as Africa, not as UCT, colleagues in different of these facilities and colleges and universities, mostly for the last 4 or 5 years. And they range similarly from direct entry, as Alice was describing, a diploma program. That direct entry for neonatal nursing is much less, we see it less often in the southern area. Probably the most successful one is in Morocco. It's almost like we've decided it's a subspecialist skill, but actually it can be a direct entry, I'm sure. I don't really know why not. So, next slide, please. Building a sustainable workforce of neonatal nurses is happening through training programs across countries and in country. And in different countries, as you can see. What is interesting, though, is that the landscape, the regulatory and the policy landscape is complex. And there's that middle little hub that sits between where nurses are educated in the universities and colleges and where we have to employ them in the Ministry of Health. And that's the regulator. So next slide, please. I'm so delighted to have heard much more detail about this from Jean-Pierre, and later, Alice, you also referred to it. A really good news when in Pretoria last year, a WHO gathering of countries in the region published a reached consensus on a health workforce agenda, which clearly included neonatal nursing. And I'm not going to repeat what that focused on. Both of the two of you, Jean-Pierre particularly, focused on what that requires. It's about getting to the point where ministries of health and in-country countries, we can match the demand and the supply. So the more we train, the more we need to employ. And I've so enjoyed watching both Alice and Dr. Jyoti from India describe that and the complexity of not being able to afford it in country. Next slide, please. The policy and regulatory landscapes can be really complex, but nurse educators and clinicians across our region definitely remain committed to training neonatal nurses. What we did and published 2 years ago was a framework from our experience of working with particularly curriculum design and colleagues in country, to assess current capacity in country to be able to align curriculum development. And there is a link to a capability maturity model, which a number of people have found really useful. To my last slide. Next slide. Thank you very much. Across the African region, we're placing the foundations in place to build a sustainable neonatal workforce. And so the news is good. Keep watching and keep building from that deep place of passion, which I know we all share, because it matters, because every newborn and every woman matters. Thank you again. That's all from me.
Thank you so much, Dr. Minette, for that insightful presentation. So we have our final presentation, and I'd like to ask you, the next final presentation might run over for the next 5 minutes past the allocated time. So please, if you are willing to remain and listen, please join us. So our last presentation will be done by Dr. Martha Mulerwa. It will be looking at biomedical engineering workforce and partnership needed to sustain neonatal technologies. Dr. Martha Mulerwa is an Associate Director, Biomedical Engineer, NEST 360. Welcome, Dr. Martha.
Thank you so much, Patrick. Since you're out of time, I'll try to summarize the slides. I'll begin by giving a brief introduction about biomedical engineering as a profession. It's responsible for ensuring that the availability and accessibility of medical devices that are of good quality and are effective for their intended purposes are available in our healthcare settings. Now, next slide, please. Biomedical engineering is an ecosystem built through partnerships and not hospitals alone. As you can see from the slide that is adopted from the Human Resources for Medical Devices by WHO, you see that it relies on 4 main contributors. The first one being government. So as you can see on your left, the government is in charge of setting the right policies, regulating the medical devices, financing and setting the standards that govern devices. We have academia and research institutions right at the center of it. And these provide education, certification, mentorship, and continuous capacity building. At the top in red, we see industry, and these are the ones that ensure that we have the equipment. This promotes innovation, service support, spare parts availability, warranties, and technical updates. And then we have the healthcare, which is the green on the right, which is where we have our equipment being used, maintained, patient safety being monitored, and the quality of our services also being monitored. For today, we're going to focus on one aspect of this ecosystem, which is the hospital setting. So biomedical engineering in healthcare is a system function and not just a repair role, although most facilities have designated this as a repair role, but it's really a system. And the needs depend on the level of the device along the life cycle. So we can broadly divide the activities within a hospital to 3 major groups. That's planning and procurement, maintenance and operations, and then safety and quality. Sorry, the previous slide. I think you're ahead of us. Yes. Into 3 main categories. So under planning and procurement, we have technology assessment, acquisition and contracting, and then supply chain management. Maintenance and operations, which is what most of us know BME for, is service maintenance and service strategy, technical management of medical devices, planning for this equipment, and IT integration. And another key aspect that really we should be looking out for is safety and quality. We have risk management for this equipment, quality and safety, are they being incorporated? End user training and incident reporting. Next slide, please. So the question for today is, how many BME do we need in our hospitals? Unfortunately, I think this being a relatively newer field, we don't have a single universal tool or ratio for estimating BME or HTM staffing. And there's also limited empirical staffing benchmarks for BMEs, biomedical engineers and technicians in low resource settings. However, there's been some recommended estimation methods. And the first one, which was used by WHO, which is a population-based estimation method, which estimates the BME density per 10,000 population for national or regional planning. We've had the hospital beds, which is the commonly used one, and it estimates that we should have 2.5 to 3 full-time biomedical engineers per 100 beds. They've also recommended use of equipment industry where 1 BMET per 800 active medical devices. So using, for example, the hospital beds estimation, that means that for a 500-bed hospital, we may need approximately 12 to 15 full-time BMET. And this is before adjusting for the equipment complexity, critical care units, such as theaters, ICUs, and NICUs. Next slide, please. So, however, although we have these recommended estimation methods, these ratios miss important workload drivers and therefore are not very sufficient. For example, when we consider equipment complexity, a weighing scale cannot be equal to a CT scanner for us to say that, for every 800 equipment, we need 1 BME. It really depends on the level of care that is happening at the facility. Then the risk level. ICUs, theaters, as we know, these would require faster response. And in most cases, we would ideally need a standby BME for a major surgery ongoing or for an ICU operation. We consider when you look at the equipment age, the older equipment this is more, think of it like a car. The older it is, the more corrective maintenance we are going to need. Then geography, service model, if we have more in-house maintenance, this means we require more staff than outsourced services. And then usually what's not considered are the non-repair duties such as planning, procurement, training, quality, and vendor coordination. So in a nutshell, final staffing should ideally be based on workload and not headcount ratios alone. Next slide, please. BME workforce varies widely per region and country. So according to the WHO estimation, they published an indicator for BME based on density per 10,000 population. And they found that there's a very low density for BME in low and middle income settings at less than 0.01 per 10,000 population. On the other hand, for Europe and the Americans, the density is approximately 2 to 1 per 10,000 population. So this means that although we don't have an appropriate tool to estimate how many we need, we actually have a very low BME in low resource settings. Although population density shows system capacity, a hospital setting still requires us to know, the bed quantities, equipment, and workload data. And this means that also the population-based estimate may not be the best tool. And finally, last slide. For our last slide, the key takeaway is that BME is more than repair, and it's a system, and therefore this should be considered when planning for staffing. We should think of activities like planning, procurement, maintenance, training, quality, risk assessment, and service coordination. Secondly, we need to use benchmarks for fast estimates, not final staffing. Final staffing should be based on our bed numbers, our population, the conditions we are handling in the hospital, and also consider device count and screening tools. Number 3 is that final staffing should be workload based. And number 4 is that training must go beyond fixing equipment. So as we are training our BMEs in the facilities, we need to capacitate them to consider the entire health technology management cycle, which runs from needs assessment to device decommissioning and disposal. 5, advocacy is needed to have more staffing in hospitals, but this should be evidence-based, and therefore we need the appropriate tool to be able to estimate the right HR. Partnerships should build local capacity, and finally, partnerships with academic institutions should strengthen hospital capacity. Being from Uganda, I give an example of Makerere University and Mulago National Referral Hospital, where we have several BME trained within the hospital setting itself, and not tied to the engineering college. Thank you very much, and that's the end of our slides.
Excellent. Thank you so much, Martha. I want to appreciate all our speakers today. Take a minute to go to the reaction and let us appreciate them. I think it was a very, very rich discussion. Now we know the norms. We need 1 to 3 to 4 non-CPAP beds and 1 to 2. And this means that we need to double the number of nurses that we have. If we look at the cost that Alice talked about, we need a huge amount of money to be able to do this, to recognize and also give incentive to the nurses. And so we need to be very creative on how we are training, make sure everybody has skills to do this. So thank you so much, everybody. And thank you, Mother, for representing the biomeds. So please post your questions in the chat. We'll be able to answer them even later. We have 2 upcoming webinars. That is on 4th of August. August is breastfeeding week, the first week. So we'll have a webinar on that. Then on 8th of September, we'll have World Sepsis Day webinar. Please join us. Next slide. We really appreciate you for making time to join. Thank you so much. A big, big thank you to all our speakers. This recording will be available soon and will be shared on our social media. So feel free to download, listen to it again, and use it for advocacy, as well as the resources that Toby was posting in the chat. Thank you so much, even for the extra time. We really appreciate. Do have a good evening and time wherever you are. We want to thank our funders in Nest 360, the whole alliance. We also want to thank the French team, Toolkit, the expert advisory team, as well as the team in London School. Thank you, everybody, and bye.